Hello, everyone. My name is Phillip Cooper. I'm one of the palliative care doctors here at St. Martha's in Antigonish. The Palliative Care Society of Antigonish Town and County has asked me to do a short video explaining what palliative care means in this year, 2021. And I'm happy to share my thoughts with you. I should emphasize that a lot of the things that I will say are my own personal approach to palliative care, which I have developed and learned over the last 10 years that I've been doing this work. I should also tell you, for the sake of full disclosure, that in my previous incarnation, most of my life, I was a general surgeon. When I semi-retired 10 years ago, it was to help deal with crises, first in medical oncology and then in palliative care. And it's in those two fields that I spent most of the subsequent 10 years, which I regard as being the 10 most rewarding and enjoyable years of my 45-year medical career. The things that I will say today will be influenced by those twin backgrounds of medical oncology and palliative care, because one thing that we have learned, and we've actually learned it only within those last 10 years, is that integrating palliative care into cancer treatment, that's oncology, actually gives people better quality of life, also better longevity, and also avoids a lot of extremely expensive, often, and futile interventions towards the end of life. So I'm going to try to clarify a lot of the misconceptions which I know exist about what palliative care is, and just as importantly, what it is not. Modern hospice palliative care is something which has really only existed for the last 50 years or so. In one sense, palliative care is very, very old. It's as old as medicine itself. I would argue that until 100 or so years ago, most medical treatment was, in fact, palliative, because the truth was there wasn't a whole lot of treatment available for many of the diseases that afflicted humanity, and a lot of the care extended beyond treatment of the disease, the causes for which were often not clear, and towards looking after the whole individual. We, I think, took a rather unfortunate detour in healthcare in the middle of the 20th century when we started with some serious treatments for diseases such as antibiotics, such as chemotherapy drugs in the areas we're talking about today. We started treating diseases and we almost stopped treating people or patients with disease. And it's my belief, it's my contention, I'm going to try and persuade you that what palliative care has done in recent years has been to reintegrate the care of the whole individual and his or her family with the treatment of the underlying disease, and to be much more holistic. So palliative care is very old as medicine itself, and yet it's very new. And most of us trace the origin of modern hospice palliative care to one individual, one remarkable individual who in the early 1970s became single-handedly the first palliative care team. Nurse, social worker, and physician. This remarkable individual's name was Cicely Saunders. And Cicely Saunders was born in the interwar years and grew up as a child of privilege and went to Oxford University and studied to be a nurse so that she could serve casualties from the Second World War. She became very interested, being a practicing Anglican Christian, in looking after people's health beyond their purely medical needs, looking after their spiritual, their existential suffering, as well as their physical suffering and their disease. And she was appalled by what she saw when it came to the care of those who were dying in hospital. The basic message was, and I remember it quite vividly myself from my medical school days, you're terminal, you have a terminal illness, there's really nothing else we can do, so the medical team will withdraw and the nurses will give you medications to keep you comfortable and to help you die, and probably help you die more quickly rather than less quickly. And the message was, there's nothing can be done. And Cicely was wise enough to realize that that was not the way we should be doing what we do. And she tried to change the situation that she saw in a teaching hospital in London, and was told, no, you're just a nurse, you're not going to change the world. So she said, well, in that case, I'll become a social worker, or an almoner, as it was called in those days in that country. And she tried again, and looking at the psychosocial needs of those people who she saw dying, usually at home, because this was pre-National Health Service days when people couldn't afford often to die in hospital. And she saw people dying in abject poverty, often abandoned by their families, in appalling circumstances, getting little or no nursing or medical care. And so she determined to try to change the situation and went back to school again and studied to become a doctor. And thereby, as I mentioned at the beginning, she became single-handedly the first multidisciplinary palliative care team, with nursing, social work, and medicine as the background. And she eventually, in the early 1970s, founded what became St. Christopher's Hospice in London, which is regarded around the world as having been the place where modern hospice palliative care began. It's the place I went myself to study on two separate occasions in the early part of this century. And the philosophy of St. Christopher's, remembering that St. Christopher is the patron saint not of lost causes, but the patron saint of travelers. This is a pilgrimage. We are accompanying people on a journey. This is not regarded as being hopeless cases. We, in palliative care, remain optimists who say there's always actually something that can be done. And we try to find out what that often quite simple something is in order to relieve people's suffering and help them find meaning in their lives, and often meaning in their deaths, not only as solitary individuals, but also as members of a wider community, in their families and in their wider community, because we believe that we all share each other's sufferings, we share each other's lives, and we should be sharing in each other's deaths. And that's part of the message of modern hospice palliative care. So what hospice palliative care is not is to say this is just end-of-life care. In other words, as some people still unfortunately say, and I hear it said, oh, you're palliative now, there's nothing else we can do, you're palliative. And that's a huge bump in the road for a patient who's been fighting often for years with various types of chemotherapy or surgery or radiation, fighting a cancer, which is traditionally what palliative care has mostly been involved with, to be told, okay, we're done with the cancer treatments, you're palliative. And the message, not necessarily spoken out loud, but nevertheless very clearly received by most patients when they're told this, is you're going to die very soon and there is nothing else that we have to offer. So that is not what palliative care is about. In some places, palliative care is considered to be exclusively about pain and symptom control. And that's certainly a very important part of what palliative care is. But it's my firm conviction that palliative care is or should be about much more than just pain and symptom control. We need to be looking at people's emotional, psychological, spiritual, existential suffering, as well as just their physical suffering. Palliative care is not about medical assistance in dying. This is something which has exercised us a lot in recent years, particularly in the palliative care world. And in St. Martha's Hospital, MAID is not permitted under the agreement signed 25 years ago this year between the government of Nova Scotia and the Sisters of St. Martha. Most of us in palliative care do not believe that euthanasia is part of what we should be doing. In fact, many believe, as I firmly do, that euthanasia is the antithesis of palliative care. We should be helping people to find meaning in their suffering and relieving them of the feeling that their lives are simply worthless, meaningless, and that they don't want to live another day or carry on living at all. So in a survey of Canadian palliative care physicians a couple of years ago, 92% of Canadian palliative care physicians expressed the view that euthanasia, medical assistance in dying, MAID, is not part of what we do. And it's certainly not part of what I do. I'm interested in helping people to live, although very often also I would say to people, I spend probably 95% of my time helping people to live and about 5% of my time as a palliative care physician helping them to die. But it's a small proportion of our overall work. So that's what palliative care is not. What palliative care is a holistic approach to the care of people with advanced disease. In modern times, not just cancer, as traditionally was thought to be where palliative care did its work, but increasingly we're seeing more and more people with end-stage heart disease, lung disease, kidney disease, liver disease, brain disease, people with severe incapacitating chronic illnesses whose deaths may not in fact be imminent, but whose suffering is real and who need help in carrying on with their lives. Palliative care is about looking after the whole person. I tell people, you are more than just your disease or your diseases. There's more to you that we need to be looking after. There are things that matter to you more than just your physical symptoms, more than just treating your disease. And when we get to the point where your disease seems not to be taking very much notice of the treatments that we're aiming at it, it's time to consider the bigger picture of how you want us to look after you as this disease gradually, perhaps relentlessly, perhaps inevitably progresses. One really important thing to be aware of about palliative care is that it is a team sport. Palliative care teams work very collaboratively and include multiple disciplines, not only nursing, social work, medicine, as I mentioned at the beginning, but also pastoral and spiritual care, physiotherapy, occupational therapy, dietitians, continuing care, VON in our community nursing or continuing care nursing in many parts of the province. These are all important, in fact, vital parts of providing the sort of palliative care that people require, bearing in mind that a lot of folks will be, as they get towards the end of their lives, they will be unable to get to doctor's offices or get to hospital visits or even to emergency departments when they are increasingly unable to get out of bed. And so the care has to be taken to them. So it's a team exercise and looks after chronic disease as well as just patients with cancer. One of the things that we have learned with scientific studies over the last 10 years is that rather than the traditional model, which used to be cancer treatment until it stops working, and then you're palliative, and there's this huge bump in the road, and you go to the palliative care team, and everyone else withdraws, we have learned that early integration of palliative care into cancer treatments in particular helps with quality of life, with life expectancy, and also, as I mentioned, it saves a lot of expensive and futile treatments being considered because people are saying, what are we really trying to achieve here by subjecting someone to some other treatment, often a third or fourth line chemotherapy drug, which will be hugely expensive, potentially hugely toxic, and with minimal potential benefit. And people need an opportunity to stand back and say, the fact that this can be given doesn't necessarily mean that it's something that I want, unless there's a realistic prospect of it helping me to feel better or live longer, or both. And if it's not going to do those two things, then I'm better off not being given it. And one of the gratifying things in palliative care often is to see people get over that hurdle in their journey, of realizing that when they get to the point that chemotherapy is not helping and stop chemotherapy, they actually feel a whole lot better. And that may be for an extended period of time, as people get on with their lives and start focusing on using their time in the most productive and positive way possible, rather than spending their time sitting in our chemo suite and getting chemotherapy, which has a rapidly diminishing return in terms of benefit compared to the downsides. So we talk about, and we help people to think about, what we call goals of care. Before we plan to do something, is this really what you want us to do? And one of the things that constantly strikes me in palliative care work is that sometimes people make decisions that we ourselves may not agree with. We may not understand them, but ultimately we have to be prepared to stand back and say, this is your journey, and we can give you the facts, we can tell you what's available, we can tell you what your options are, but ultimately it's your journey and it's your decision, and we will walk with you with that decision. But sometimes that can be difficult. But with goals of care, we're talking about issues like, where would you wish to spend your final days and weeks? Where would you wish your care to be provided? A lot of people will say, well, of course, I would want to come into hospital. But nearly always, in my experience, that is as a result of a selfless concern for family who people feel should not be obliged to take care of their dying relatives at home. And when you actually ask the family, they will often say, well, no, that's actually what we're here for. That's what we would want to do. And we would be prepared to put up with the inconvenience and the commitment of looking after you in your end-of-life care. And it's one of the most gratifying parts of palliative care to help people work through those goals so that they can stay at home to die at home, if that's what they choose. And a lot of people do that, but they need a lot of extra help and support. And there are a variety of different ways that we can provide that support through nursing and through the emergency services and the like, so that folks can actually stay at home. And a lot of the work of the palliative care team is actually done in people's homes. We don't expect people to come to our offices in the hospital to receive the care and the advice that they need. We will very often go to them, and I spend a lot of my time seeing people at home and helping them to die at home. Part of the goals of care discussion is a discussion about advanced directives, and people need to think through, and it's very difficult for families often to address the realities of what's happening and to plan for what might be ahead. But one of the little mantras of palliative care is hope for the best, but prepare for the worst. So we ask people, things are going well now. This is a time to be thinking how you would wish us to look after you when that changes. If, for example, you suddenly deteriorated, if you collapsed, if you stopped breathing, if your heart stopped beating, what would you want us to do? Would you want the paramedics to be called and to come and assume that you've had a heart attack and jump on your chest and put a tube in your lungs and take you to hospital to be put on a ventilator? To which most people that we look after with advanced cancers will say, well, of course not. That would be ridiculous. That would be absurd. That would be futile. And I say, well, yes, you're very right. But until you have stated and we have documented that that's not what you want, that's what will happen. And so These are important discussions to have. Most people don't have a will, for example, and need to be reminded about having their wishes for their end-of-life care and their wishes after death as well, with the will documented and having all those affairs in order so that they can forget about dying and get on with living. So these are really important parts of what we do as well. Now, I'm speaking to you from the family room in the palliative care unit here at St. Martha's. I'm proud to sit in front of this magnificent quilt, which was made a couple of years before the unit actually opened by the ladies of the CWL, the Church Women's League at St. Ninian's Cathedral here in Antigonish. And each of the panels was made by one of the women in that group. And it is a beautiful piece of work. And as you can see, there are lots of loving expressions of hope and healing and smiles and caring and family that help to give a very peaceful atmosphere and a positive message to the families and patients who use this room. Our unit here at St. Martha's opened after a long, long battle with various versions of what we might have had. We finally opened the unit nearly 3 years ago, and it has certainly made the work that we do a lot easier for the patients that we serve. One important thing that I think many people don't understand is that hospice palliative care, in the way in which the term is used in the States, it's quite different. When they talk about hospice, they mean a residential care home for end of life. That's not what we mean by hospice palliative care in Canada. Hospice palliative care is not a place, it's a philosophy of care. And hospice palliative care can be provided anywhere. We do hospice palliative care in the intensive care unit. We do hospice palliative care in the regular wards here at St. Martha's. We do hospice palliative care in nursing homes. We do hospice palliative care in people's homes. So it is a philosophy of care, not a physical place. And hospice palliative care is mostly provided out of institutional settings in people's homes. Now, the beautiful thing about our unit here at St. Martha's is that now we've finally got it, it's all paid for, and people often will wish to give funds to support the work of the palliative care unit after their loved ones have died here. But the truth is, this unit doesn't need it. The place that needs the funds is the care that we do, supported by the Palliative Care Society in the community. And that is in providing equipment, loans of things like hospital beds, oxygen concentrators, wheelchairs, walking frames. There's a whole list of things that we can do to help people be comfortable and safe and stay at home for their end-of-life care. We also have a small amount of funds that we give to those who are in financial distress for getting to appointments in Sydney or in Halifax, for example. So those funds that are raised by the Antigonish Town and County Palliative Care Society, on whose behalf I'm speaking to you today, are vitally important for the support of the work we do, not here in the palliative care unit in the hospital at St. Martha's, but out in the community. That's where most of the work that we do actually goes on. And you may be surprised to know that most people still die outside the palliative care unit. Many people still choose to die at home, and we do everything we can to help them to do that, but it does require resources, and those resources have costs attached to them, and that's where the fundraising work of the Antigonish Palliative Care Society is so vitally important. One of the things that has changed in the last 10 years as well is that there has been a realization that palliative care was grossly under-recognized as an important need in the decades indeed, when we were treating diseases rather than treating people. And there is a realization that there will never be enough palliative care nurses or palliative care physicians to care for all the end-of-life needs of people with cancer, certainly not all those with the other chronic diseases as well. And so we have an important responsibility in disseminating within the healthcare system a philosophy of what we call the palliative care approach. And this has been a very important part of the work that we've done, in that not only does it encourage people to ask questions about the wisdom in the bigger picture of what they may be proposing to do for an individual patient. Just because we can do something doesn't necessarily mean that it's in that patient's best interests. But also, we are encouraging physicians and nurses to have a mindset which focuses on treatment of symptoms and aims at improving quality of life as well as just treating disease. And I think that palliative care has changed the way a lot of people do medical care in the last 10 years or so, so that it's only a small proportion of the actual palliative care work that is done by specialist units, and increasingly we have been able to persuade physicians, family physicians, nurses, hospital physicians, that they're part of this palliative care approach as well. One of the philosophies that has become widely accepted now is what flows from a question which is encouraged in primary care called the surprise question. And the surprise question asks, mostly of family physicians, would you be surprised if the person sitting across the desk from you were to die within the next year? And if the answer to that question is no, I wouldn't be surprised, then that triggers a whole series of conversations about preparing for the end of that person's life, so that it doesn't all come as a big surprise with no preparations made. But that is done within the philosophy of palliative care, which says, hope for the best, but prepare for the worst. Now, Cicely Saunders, Nurse Cicely Saunders, Dr. Cicely Saunders, later Dame Cicely Saunders, is no longer with us. But her huge influence lives on in the Cicely Saunders Foundation in London and the St. Christopher's Hospice in London, but also in the palliative care units literally around the world. And there's a lineage of education that was sent from what Dame Cicely did at St. Christopher's to Canada and to the United States and to Australia. And most palliative care in the world traces its origins to the work of this very humble and very determined woman 50 years ago, Cicely Saunders, who I would honor today, and commend to you a recent biography of her which was written, which explains the influence that she's had on the way we help people at the end of their lives well into the 21st century. Thank you for your interest. Thank you for your support for the Palliative Care Society. Please look at other parts of this website. There's an area where you can donate if you so choose. We have fundraising activities going on through the year. If you would be interested in volunteering to join the board, I've been on this board now for the last 10 years myself in an advisory role, and I can tell you that we have a lot of fun with committed, dedicated volunteers determined to improve the quality of life at the end of life for the folks in the areas we serve. Thank you.